I'm going to wait. Hi, good morning, everyone. Welcome to the first grand rounds for the academic year of 2020 to 2021. Today we have Dr. Bridget McCandless here with us as our first visiting professor of the year. She is a retired president and CEO of the Health Forward Foundation. The foundation worked to ignite a culture of health by focusing on those in need in 6 county areas surrounding Kansas City. Since its inception, the foundation has invested more than $300 million in service of its mission. She has served on the American College of Physicians Health and Public Policy Committee, the Missouri Medicaid Oversight Committee, the Missouri Women's Health Council, and the board of the Truman Library Institute. She continues to work on issues related to healthcare access and social contributors of health. Dr. McCandless received an MD from the University of Missouri-Columbia School of Medicine, completed her residency in internal medicine at the University of Virginia, and received an MBA in healthcare leadership from Rockhurst University. Prior to joining the foundation, she served as founder and medical director of the Shared Care Free Clinic. We are elated to have her here today to discuss Medicaid in 2020.
Thank you for having me. I am delighted to join you from beautiful Kansas City and to talk about one of my passions, which is Medicaid. It is fascinating that I went through all of that training, college, med school, residency, and left completely unprepared to understand the financing, structure, regulation of the world of healthcare. And so as I went through my work, I realized that I was going to have to understand those pieces because I could not advocate well for my patients unless I understand how the system worked. I did my training at UVA and found out that who I particularly appreciated caring for were vulnerable patients. So those patients were the ones who I felt I could do the most good for. And I realized that I could fix the patients one patient at a time, but the legislature could change the rules by the tens of thousands with the stroke of a pen. So unless I understood how to speak state budget and understand the structure of Medicaid, I wouldn't be able to do as good a job for my patients as I should be able to. And I will tell you, it is amazing how many people who work in state legislature don't really have a good functional understanding of Medicaid. So one of my jobs here is to be able to teach you to talk about Medicaid in terms that are easy to understand, both for you, your colleagues, and other people who are interested in this issue. These are my basic learning objectives. I want to help you understand the relationship of the federal poverty level to both Medicaid and other services. I want you to be able to easily articulate the basics of Medicaid eligibility. I hope that at the end of this, you will recognize the innate complexity of the way that our system currently works. And MoHealthNet, as you know, is what we call Medicaid in the state of Missouri, one of the issues of complexity right there. And I'd like you to be familiar at least with some of the health and financial effects that have happened in states that have chosen to expand Medicaid as opposed to Missouri that does not. As with all presentations, you need a disclosure. I certainly hope that at some point in my life, I will be able to have financial disclosures for you, but at this point, I do not. The second is that I am an unpaid volunteer on the Missouri HealthNet Oversight Committee. This is advisory to the state legislature. There are a number of physicians and other health professionals who are on that committee who talk to the state about how Medicaid is functioning for our patients, for the state, and for the providers who care for our patients. So you may be completely familiar, you may speak fluent Medicaid. I'm guessing that you don't. But just to start at the beginning, I am from Independence, and there's never a chance that I give up to talk about Harry Truman. So in this photograph, you can see 55 years ago when President Johnson came back to Independence to sign the Medicaid and Medicare Act in the presence of President Truman, because Truman had started all of the work that it took to get these programs into place, and President Johnson was able to get them across the finish line and get them enacted 55 years ago. The partnership between the state and the federal government is a very important one, but it adds some complexity to the system. The federal government pays a portion of the funds to run Medicaid, and the state comes up with the balance of that. As I say here, it's administered by the states, so you actually have 50 unique programs that are operating, and each one receives a different amount of money. So in poorer states, the federal government gives more money. In states that have a higher per capita income, there's less money. So the minimum that the state has to put, the minimum that the feds have to put up is 50% of the cost. So in Connecticut, Rhode Island, some of those states, they're close to that 50%. Mississippi has the lowest per capita income. They get the highest federal share rate. So theirs is close to 80%. So we're going to talk about Medicaid and a little bit about CHIP, which is the Children's Health Insurance Program. This wheel here shows the total coverage of health in the United States. You can see that roughly 9% of the US is uninsured, about 50% is employer-sponsored health care. Medicaid and CHIP, or Medicaid and the Children's Health Insurance Program, cover about 20% of the population, Medicare covering 14%. What's important about Medicaid is the number of people that it covers who are vulnerable. It is the largest payer of all nursing home costs in the United States. That's extremely important because when we begin talking about Medicaid budget, we talk a lot about children and moms. We almost never talk about seniors and disabled who are in nursing homes, and yet the preponderance of the costs are in that group. It's also important to know that 2 out of 5 children in the United States are covered by Medicaid. That is a great reflection on the number of children who are living in poverty in our country. And so as Medicaid policy changes, its impact on children and families is profound. The federal poverty level is set each year, and the federal government determines that 100% is the cutoff for being poor. Everything above that, they consider you not poor. Everything below that is considered poverty, and we will talk about it as percentages. You can see that being poor in America is not considered, doesn't come with a large price tag. So for a family of 4, $25,000 per year is considered the poverty level. The reason I put the 22% of federal poverty level is because in the state of Missouri, that's the percent that we cover parents. So you can see that for a family of 4, you can have no more than $5,700 for a family of 4 in order to qualify for Medicaid as a parent. The 138 is the cutoff for the Affordable Care Act expansion. And so we're going to talk a lot more about that, but I just want that to be foremost in your mind as we start to move forward. The federal poverty level is used to determine free and reduced lunch at school. It's for utility assistance. It is for housing. We use it for almost everything. It's such an important federal tool that I hope you take a minute, and I'm going to give you some homework. Your homework is to go out and type in Federal Poverty Calculator 2020 and put in what you think your annual income is or would be so that you can get a sense of where you fit, because we're going to be talking about the difference between 135% of federal poverty and 138% of federal poverty. But if you look, this is where the average internist salary for 2019 at 729% of the federal poverty level. So when we begin talking about these very small discriminators in the federal poverty level, it's helpful to know how far away most physicians are from the levels we're talking about. As I said, it is a federal-state partnership, and the state partnership is the implementation phase of it. But there are certain things that everyone is required to do. So all states are required to cover mandatory services, which you can see here. And then there are additional optional services that the state can participate in. It is fascinating to see that prescription medications are considered optional. PT and OT are considered optional. So they have to pay for the surgery for the knee replacement, but they don't pay for the rehab afterwards. Now, some states have a very generous package, other states do not. The optional coverage is often done through what we call state waivers. So the state asks permission of the federal government to add certain coverage services. They can either choose to pay for those themselves, or they can say, we know that if we use OT and PT, it will save the state so much money in rehab that it is net neutral for the federal government, and then they give them a waiver to allow them to add those services. The state of Missouri recently added dental services for adults, which was a huge win. That took about 10 years of lobbying to be able to get that added, and that was added 2 years ago. It's made an enormous difference in the well-being of adults with oral health issues. Obviously, the state of Missouri covers prescription medications. We do not cover PT and OT. The consequences of that have been enormous for the number of people on Social Security in the disability category because we do not cover those services. So when we talk about Medicaid, Medicaid is what we call a categorical program. It gradually grew over time and they added more groups of people to coverage. So when I explain this to people, I say Medicaid in Missouri is a poor and. You must be poor and pregnant, poor and elderly, poor and blind, poor and a custodial parent, poor and handicapped or disabled, poor and child. The reason this matters is because there's no category called poor and sick. So you cannot have type 1 diabetes and be in the category of poverty and qualify for Medicaid. This is a critical misunderstanding at the state level. Many people think that if you are low income, you make an application, you're automatically on Medicaid. We have built a system where you must get to the point of being declared disabled before you qualify as an adult without children. As you might imagine, you have a number of working aged adults who have chronic medical needs who fit in this category. I'm going to start by talking about the aged, blind, and disabled category, and this is the federal designation called ABD. Part of the complexity of Medicaid is that the income level for each category is different. The requirements of paperwork are different. The application is different, and the state has to manage all of that. We have roughly 850,000 people in the state of Missouri who are currently receiving Medicaid benefits, and each one of these categories comes with an enormous raft of complexity. We do that in a system that is built on a 1978 COBOL platform. So the guts of the IT system for the state of Missouri Medicaid is abysmal. And so making changes is impossible. And if anybody here remembers COBOL, we almost have to do a seance to get enough coders who can come in who still remember that old system to be able to make tweaks. So the state really has a hard time making adjustments. I admire very much the current director of Medicaid who is willing to take on some of the modifications needed for this, but it is not a small undertaking since that infrastructure has been ignored for years. So the work needed to do to prop it up and to transition to something more modern is going to be really substantial. So as you can see here, each one of these federal poverty levels is different. So 85, you can't just be poor to be a senior to get Medicaid. You must be less than poor. You must make only 85% of the amount that we consider the poverty level. In Missouri, we have a very complicated application system. Our application system is 64 pages long. There's only one state that's worse than us, and they are 65 pages. So currently, Missouri HealthNet is working to try to simplify their application, and I hope that they are able to do that because the application process is really onerous. The other thing for people who are applying under disability is that they have to have a medical review. And within 90 days, the state is supposed to do a review of all of their past health history to be able to determine if they are disabled and able to come on Medicaid. With a lot of uninsured people, they have had extremely fractionated care. So their ability to put together all of those resources in one place for review is really hard. Some of them may not be seeking care anywhere, so there is no paper trail for them to be able to come in as a disabled person under the system, so they would be automatically denied regardless of the health issues that they're having. We also are what we call a spend down state, which means that we allow people to get poor enough to turn on their Medicaid. So for those people who are 85% of poverty, the disabled and seniors, they are able to spend that portion of their income on medical expenses every month, mail in all those receipts to the state, and then the state will turn on their Medicaid for 30 days, and then they shut it off, and then they have to, again, submit proof that they have spent down, and then they will turn on for another 30 days. So you may have someone in the midst of their treatment who is too sick to keep track of their paperwork, or the paperwork doesn't arrive, or they haven't spent quite enough, and they will then not have Medicaid. The reason this group is so important is that it is very complex for the state to administer them. And why it's so important for you to understand is you may have people who come on and off Medicaid all the time. They may beg you to give them meds for 3 months so that they can shut off their Medicaid for the 2 months in between seeing you for their doctor's visits. They may show up and not realize they hadn't submitted the paperwork, and they may not have Medicaid when they come to see you for your visit. So understanding the complexity of this is really important for you as providers. Now, seniors and disabled who fit into another special category can actually have both Medicaid and Medicare. We call them dual eligibles. So if the disabled person has been totally and permanently disabled for more than 48 months, they automatically receive Medicare. And if they are still below that 85% of poverty, they can receive Medicaid. The reason this matters is because they get some wraparound services, and they no longer have to pay the copays with Medicare. Medicaid will pay their deductible, it will pay their copays, so that those people who are considered in that very, very high risk category are financially protected from out-of-pocket costs. But you'll hear a lot of research going on when they talk about the dual eligible, so that's Medicare and Medicaid. So families and children really make up the bulk of the number of people enrolled on Medicaid. So we cover pregnant women up to 185% of the federal poverty level. We do that as well as any other state in the United States right now. We also cover children's health insurance up to 300% of federal poverty. I'm going to talk about that on the next slide. It's important to acknowledge the state when they do things well, because there's a lot of things that I've already talked about that I don't think we do well. These are two categories that we do a really nice job of. Presumptive eligibility means that if you see a pregnant woman, you can assume that based on a rough guesstimate of her income, she is going to be qualified for Medicaid. You can begin taking care of her as though she is a Medicaid recipient. And at that point, when she qualifies, there will be a look back, and the hospital and you will get paid as long as you remember to submit. So that look back allows you to do presumptive eligibility and recoup your costs. It is critical to remember that we will take care of the mother until only 60 days after delivery, regardless of her health, complications of pregnancy, or any other issues that she may have. Now, we did pass a law that allowed us to extend substance use disorder treatment to women past those 60 days. However, when she admits to substance use disorder treatment, she then is at higher risk for losing her children if that treatment doesn't go well. So there's reasons for her not to want to admit that. And we have not gotten it budgeted. So while it's on the books, it didn't make it into the state budget. So that category of program has not yet been implemented. And then we come to custodial parents. So a custodial parent means that you are the primary caregiver, that the child is in your home. And a custodial parent, as I showed you earlier, can only make 22% of the federal poverty level. We are the lowest in the nation for covering custodial parents. And because of this, we've done a really bad job for our families. We know that when parents have coverage, their children get more medical care. That when parents have coverage, their children are more likely to be vaccinated, they're more likely to make their well child visits. And so coverage for parents makes a lot of sense. Not to mention that when you're talking about the levels of poverty required to qualify for this, the amount of stress, depression, and anxiety that comes with living in that abject poverty has real implications for the mental health and well-being of the parents, and by consequence, the mental health and well-being of the children. It is also important to realize that these families have to reaffirm their data every 6 months. If you move, they will not forward your mail. If you don't remember to tell the state your new address, you may be lost to that follow-up. Not to mention that the letters are written much beyond the reading level of many of the clients. They sound very threatening. They come in an official envelope. And so it's not uncommon for people not to fill out the paperwork and then show up with their kid and not have Medicaid. So during the pandemic, because things have been so tough at the state, they have stopped doing this reapplication, which is good and bad. The good is it means that people don't have to do the reaffirmation and they still can continue their benefits. The bad is they don't get used to seeing that letter come every 6 months. So then when it shows up again, they don't recognize it and you have a big lag time while people fall off Medicaid. We have 520,000 children in the state of Missouri who qualify for Medicaid or the Children's Health Insurance Program. That just lets you know how many of our kids are living in poverty. So we do some things well with this program. You can see that under the age of 1, we cover kids up to 196% of federal poverty level. At their first birthday, it drops to 150%. So a lot of parents don't realize that if they come for their child's well exam on birthday plus 1 day, they are now in a different program where they have to pay health insurance premiums. So the Children's Health Insurance Program sits on top of Medicaid. And what it does is it allows people to buy subsidized insurance, generally extremely affordable. So the premiums are somewhere between $4 a month and $36 a month. So that allows them to buy a children's health program that behaves just like Medicaid, has all of the same coverage aspects, and they don't have to go through the complexity of commercial insurance. So Missouri does an excellent job. We get an A+ for our coverage of kids up to 300% of federal poverty. One of the areas we've fallen down is that because we have such a complicated and poorly functioning computer system, and because families are transient, we, for a long time, didn't have anyone do any of their reapplications. And then we started doing them, and we lost 80,000 kids in 6 months who all still qualified, but who had not done their paperwork. And so it has been extremely disruptive to care. So since we've had 55 years of this, there have been some fantastic studies that have gone looking at the benefits of Medicaid. So a variety of people do these studies. So think tanks do them, foundations do them, the Federal Reserve does them, economists all over the world look at our Medicaid system. And lots of universities look at these issues as well. So you have a variety of approaches and different looks at aspects in Medicaid, and I think it really leads to some interesting questions. And as I said, you have 50 different experiments going on because each state structures their Medicaid slightly differently. So you can look at permutations of policy across all of these natural experiments. There was a 40-year study that was done looking at children who received Medicaid, and the impact on their education and their school outcomes you can see here. So more likely to graduate high school, more likely to graduate college. And from health standpoint, they also had markedly reduced treatable diseases. So heavily in the asthma and infectious disease category improved. You can see better adolescent health outcomes, reduced rates of teen pregnancy for children who have easy access to care, both in counseling and in easy access to birth control. Fewer hospitalizations and ER visits at age 25. So I'm lucky, my kids have never been in the ER, my children have never been hospitalized, but looking at that reduction of up to 13% for the bottom line of a hospital and for the health and well-being of young people, you can see that that makes a substantial impact. So as internists, we spend most of our time with adults. So the final one impacts us very much. So 26% less likely to have hypertension as an adult. We think a lot of that has to do with financial security, general baseline stress, as well as being able to treat comorbid conditions early, like obesity. I am a policy nerd, so I always look at the financial implications of everything. And for the children who have been on childhood Medicaid, and the definition was more than 1 year, higher incomes later in life, and they had greater economic mobility. This is really nerdy, but it basically says that the tax payment that those children had during their lifetime actually pay back to Medicaid a percentage of the tax dollars that were invested in them young. So you can see by the time these people reached age 60, 32 cents on each Medicaid dollar had been paid back to the federal government in taxes. Now that's only returned to the federal government. This study did not examine return to local or state governments. So this is a busy slide, but it showed that since 2000, we have seen a steady decline in the United States of the rate of uninsured children. Now, I underlined the word was because it was at a record low in 2015. Unfortunately, what we are seeing is that is beginning to tick up. And as I said, in Missouri, we have seen a substantial increase in the number of uninsured children. Let's see if I can move this. And so it's important to know that usual source of care and well child checkups, much better in Medicaid, almost on par with employer-sponsored health insurance. So almost half as much for well child checkups in the uninsured population. I think there are a lot of misperceptions about who benefits from Medicaid. And it's 71% white in the state of Missouri. It's also full-time workers. You can see how much money you would have to make for the 138% of federal poverty. That's the expansion number. As we talked about before, custodial parents can make much, much less than that. 71% of the households have at least one full-time worker. And this is, when they did this, they went through and they took all of the people who were not Medicaid eligible, all of the people who were not children, so work status for adults who you would expect to be in the workplace. It's also important to know that the non-workers, many of them self-describe as disabled already, but have not been able to get the paperwork necessary to be able to be declared disabled or to be treated so that they don't have to be disabled. I'm sure you are familiar with the Affordable Care Act of 2010. And just to step back to that for a minute, what the Affordable Care Act did was it changed the rules for Medicaid from that categorical program we discussed. So it changed it from poor and to just poor. So it changed the program to an income-based program so that you did not have to fit into any of those particular categories. It was just based on income. Now, when the Supreme Court ruled on the portion of Medicaid, the portion of the Affordable Care Act related to Medicaid, they said that the way it was written, which said that if you didn't participate, you lost your Medicaid dollars, was coercion. And so each state was allowed to opt in to the expanded Medicaid at their discretion. So some states came in right away, some states have not come in. But what we found is that with the healthcare subsidies, there's a group of people who have no coverage. They are too poor to qualify for the subsidies on the marketplace. So I just want to be sure that's really clear to you. You can be extremely impoverished and be eligible for Medicaid. You can, if you're above 100% of the federal poverty level, you can get market subsidies. But if you are below that 100% and above the 22% as a custodial parent, you may not purchase with subsidies. You have to pay full price. So that group of people, we consider them in the coverage gap. The blue states are the ones that have already expanded Medicaid. The orange states are the ones that have not. And then the striped states are the ones that have passed it, but have not yet implemented it. And Oklahoma passed it just in June, and their implementation date will be later in 2021. Some of these states passed by initiative petition, some passed by legislative action. So initiative petition means that the people of the state may petition to put this up for a public vote. So Utah, Idaho, Maine, all came, and Oklahoma and Nebraska, all came in by initiative petition, which means they put it up for a vote to the people, and each one of those states passed it. And then their legislatures had to implement it. Not all states have that opportunity. Missouri is one of those. We'll talk about that in a minute. It's never grand rounds unless you present a case study, and so here's one. This is a 32-year-old G1P1 woman who delivered a term female infant. Her pregnancy was complicated by hypertension. She qualified for Medicaid during her pregnancy, and her hypertension was treated appropriately. She comes back to see the baby's pediatrician 3 weeks postpartum. She reports that she has intense fears for her daughter's health. She is sleeping poorly, she is tearful, and she's having trouble performing her ADLs. She's sent back to her OB/GYN. She's screened positive for postpartum depression. She is treated appropriately with sertraline. They set up a dosing escalation plan and a follow-up plan. But her income is 66% of the federal poverty level. She is a custodial parent, which means that on day 6 postpartum, she no longer qualifies under the pregnancy care. She makes too much money to be able to qualify as a custodial parent. So she no longer has Medicaid. She is advised to find a clinic that cares for the uninsured. This is not an unusual situation. This woman is going to have a hard time finding a place that cares for the uninsured. We know that there are probably 5 times as many people looking as there are spots for care. She may go to a federally qualified health center and pay on their sliding scale. She may find a charitable care clinic. It may be that the institution she is at has a charitable care program and allows her to stay, but regardless, she is going to have difficulty finding and paying for her medications if she is just given a script and sent out the door. She also remains at extremely high risk for her well-being and for the well-being of her child. So as I said, there are expansion versus non-expansion states. So while we have those 50 natural experiments going on how you run a Medicaid program, we now have 37 states that have expanded Medicaid at different times over the last 10 years. And we're able to look at how those provisions work. So Missouri is now surrounded by states that have expanded or will expand Medicaid. Kansas is working on it through their legislative process. But it's going to be fascinating to see how those states have done. I think probably Arkansas and Iowa are the two closest to the political system in Missouri, and their data is beginning to roll in. If anybody on this call is a super policy nerd and wants to go read a nice summary of the studies that have been done, there are 404 published studies. There are about 250 that are already in process and some that are in the planning phase, looking at the effects in expansion versus non-expansion states. This summary slide from the Kaiser Family Foundation in green shows the states that have shown a benefit for the question that they were asking. The blue are ones that showed mixed findings or no difference, and the orange are the studies that have found negative effects from Medicaid expansion. You can see that the net preponderance of studies has shown benefit, and we'll talk about a few of those. I think access to care is one of the most obvious ones, from being able to have easy access to Medicaid services. They showed an increased use of primary care services, increased access to mental health services, and actually a dramatic increase in enrollment in substance use treatment programs and medication-assisted therapy. That actually has follow through in some of the economic studies I'm going to show in a minute. From the chronic care, a couple of easy studies showed increased fill rate for diabetes medication and antihypertensives. They've shown increased compliance with people staying on their medications, meeting their fill dates at the 30 days. There were two that just came out showing that fill dates for asthma prevention medications have gone up. Schools are reporting that the number of visits to their school nurses has gone down for asthma exacerbations. And you would say, well, this is primarily going to affect people who don't have kids and custodial parents. But remember, as I said, when custodial parents get coverage, their kids get better care. And those kids are more likely to be enrolled when the parent enrolls. So even though those children may have been eligible the entire time, they may not have actually been enrolled. So there's what they call a welcome mat effect. When you extend this offer to the parents, more children come on coverage. So we're starting to see a lot of benefits for childhood asthma and childhood depression as well. The one that I love is that the number of scripts for smoking cessation products has exploded. And when we look at tax data for tobacco and nicotine products, those are starting to fall. So that has long-term implications. The uninsured rate obviously went down in non-expansion states twice as fast as it went down in, excuse me, let me say that more clearly. The uninsured rate went down twice as fast in the expansion states as it did in the non-expansion states. And it's important to know that racial disparities improved dramatically in coverage. Now they still exist, but you can see that, see if I can use my handy dandy pointer here, that in the expansion states, you saw an improvement by 2018. In the non-expansion states, only half as much. And you can see how much of the disparity was erased in the non-expansion states compared. You still have this great amount of African Americans who are not insured in the non-expansion states, and they cut that almost in half in the expansion states. I must point out that the Hispanic uninsured rate is the highest in the nation. That really was not affected as much as it was for African Americans. The reason was If you are undocumented, obviously Medicaid does not extend to you. And if you are undocumented, you are prevented from purchasing on the exchange. You are legally barred from buying insurance on the exchange, even if you were able to purchase it. So it's important to know that the insurance benefits have not applied equally. In the expansion versus non-expansion states, better self-reported health and mental health status, diabetes self-management, mortality for end-stage renal patients because they were more quickly referred for therapy, they were better able to manage their access, and a reduced rate of infection. And the one that I think requires special attention is infant mortality rate. In states that are non-expansion states, our infant mortality rate went up. And in the non-expansion states, it went down. So that spread actually has been increasing over the last 10 years. Especially, this was noted among African American infants. And in Missouri, we have 3 times the infant mortality for Black babies as we have for white babies. So our obligation to attend to this is paramount. So these are some of the infographics that have been shared widely by the Center on Budget and Policy Priorities of some of the benefits of Medicaid expansion. I'm always glad to see people with a personal physician or a usual source of care has increased. Emergency room use did increase when Medicaid expansion happened, but the number of uninsured people seeking care in the emergency room was cut by 30%. So the people coming in at least had a way to pay. Now, if the emergency room is either the most convenient or the place you have always gone to seek care, it is not surprising that you would see emergency room use increase. In states that expanded more than 5 years ago, that has leveled off and the number of primary care visits has had a commensurate increase. So people are using services in the way that is best and the most economic for the state. So it takes a while for people to get connected to the system, to have faith in the system, and to have the system accommodate those new patients. Mortality actually fell in the expansion states. And so they looked at people between age 55 and 64, and they compared the 6 years before and the 4 years after implementation. And so you can see the drop in mortality post-expansion. When the economists extrapolated this data to the whole country and said, should the entire country have expanded Medicaid at the same time, that would have resulted in 19,000 fewer deaths among low-income 55 to 64-year-old people. The map shows the poverty rate in Missouri, and the dark blue is greater than 25% of people living in poverty. And you can see that in Pemiscot County and Mississippi County, down in the Boot Heel, that the rates of poverty are extraordinarily high. They are close to 30% there. So in the county that we are in, Boone County, it's 16.8% living in poverty, but you can see that there are extreme pockets of severe poverty and severe childhood poverty in the state of Missouri. So while the health benefits are important, I think the personal finance benefits of expansion are equally important, with reduced medical debt, better credit scores, out-of-pocket costs went down around $200 for families. But Montana saw an increased labor force participation, both in seeking and maintaining employment because people were in better health. Now, Missouri has a poverty rate of 13%. If we reduce poverty by 1%, as they saw in expansion states, that would be profound. I just put this up because it's important to know that 34% of the kids in Missouri live in a household with medical debt. That means people are making different choices for their kids than they would if that were not the case. But in our low-income families, 53% are living in a household with medical debt. That's unconscionable. I'm just going to touch on hospitals. Needless to say, you have more people paying, you have reduced uncompensated care, and rural hospitals are 50% less likely to close in the expansion states. I'm getting close on time, so I want to be sure you have time for questions. I will tell you that we spent a lot of time looking at state budget effects because there is no sense in having a policy that bankrupts the state. The states that have expanded have actually seen a net budget benefit when you look across the entire budget, and we think the same would be true for Missouri. There are two just weird studies that I think are interesting. One is that expansion states saw a lower rate of divorce because people were in less financial hardship, and they saw a considerable decrease in their total crime rate and their poverty crime rate. We have the option to vote in Missouri because we are an initiative petition state. Like I said, we're talking about raising it to 138% of the federal poverty level from this 22% of the federal poverty level. And the initiative petition will be to amend the Constitution. And it basically says, in the simplest terms, it means we participate in the Affordable Care Act to allow people 19 to 64 to participate. We don't make it harder for them, and we ask the state to do the job they're supposed to of implementing it. This is just the budgetary analysis showing that we think that it is state beneficial. And in summary, Medicaid expansion changes it from poor and to just income-based. It brings in $5 million per day of federal funds. We think there'll be about 250,000 enrollees. I have to give a shout out to WashU for being a phenomenal leader in this space. Being a thought leader, being part of our budgetary analysis, really educating the people who are part of your system and making sure that they make voting the easiest that they can. So I am happy to answer any questions. Feel free to reach out to me. I am happy to answer questions. These are the working hands of people who get to benefit from the opportunity to continue to work because they're healthy. And I know that I am supposed to give you a QR code so that you can get credit for Grand Rounds. I want to say a very special thank you to Dr. Kadiwada and Mr. Fields for helping make this possible today. So thank you.
Okay. Thank you so much, Dr. McCandless, for that wonderful talk. I think that was very informative for our audience. We have several new faculty and trainees currently in St. Louis, and depending on where they came from, this is all new information. One question that I see coming in here is there any polling that's been done that can speak on our chance of passing Amendment 2?
So when we cooked this cockamamie scheme up to put this on the ballot, we polled like crazy, and it polled exceedingly well among committed conservatives, among people in the southern part of the state. And it was surprising both how many people understood Medicaid and had a family member with Medicaid. So you don't enter into one of these campaigns lightly. They cost about $10 million. So we had to be sure that the polling was favorable, and the polling has continued to be favorable. At this point, it isn't about polling. At this point, people have to get out and vote. It is an off-cycle election. It is the middle of summer vacations. People are thinking about going back to school. It is a tough time for an election. So it is important that you get your friends, neighbors, grandmas out there to go vote because a few votes are going to swing this.
Great. I thank you so much for answering that. We're getting several other questions here saying that, given the data that you presented, how can anyone, regardless of income or political stance, vote no on expansion? What are people or legislators saying that this is bad for the state? What data do they have to support that?
There are philosophical objections saying that it is government overreach and that people should be responsible for getting their own health care, and really that this isn't the government's job. There are other people who are concerned about the finances of it, and I will not pretend that there are not costs to the federal government for this program. Missourians are already paying those federal costs. They just aren't coming back to the state of Missouri to help us pay for the people here. So if you are someone who worries deeply about the deficit, I cannot pretend that this is not a federal cost. However, when the Affordable Care Act was built, it was built with pay-fors. The whole bill was built with pay-fors from pharmaceutical companies, managed care companies, medical device companies. Now, those have been eroded over the last 10 years as Congress has been rolling them back, but it really was built so that it was sustainable through mechanisms of payment that did not require income tax increases. Now, what happens with the federal budget, whether there will be tax increases on the horizon, that I cannot speak to, but I know that shortchanging the residents of Missouri while other states are taking care of their workers is not good economic sense for us. We have to decide where our priorities are, and a healthy workforce and healthy parents are part of that priority.
Great, thank you. One thing that I mentioned that I noticed throughout your presentation was that there's this large barrier of paperwork, and this seemed to be a recurring theme. Is the state making any decisions regarding that and trying to streamline the process for its people to enroll in these programs and stay enrolled in these programs as they remain eligible with the way that things currently are?
I will tell you, I am so impressed with the current Medicaid director and his team. They are working very hard to try to simplify the paperwork. I think that within the next year, we will have a process that is much easier. Now, in the meantime, it's tough. The other thing is that if you do Medicaid expansion, you automatically simplify the paperwork, because you no longer have to come in under that disability stream. You just have to provide proof of income. So how fast the state can prepare for that I don't know. But you know, they know this is coming, so they've been working on what that would look like, and I am hopeful that they will be ahead of the game to be able to test drive that and make it seamless for people. There are also questions in there that are really off-putting. So the second question is, what is your social security number, meaning the parent? If I'm undocumented, I read that saying, well, my kid can't possibly qualify even though they were born here because I don't have a social security number. And so we see a large abandonment at that spot. So people drop off the application at that point because they think they aren't qualified, their child isn't qualified. The other is that when it asks for the parent's income, they mean parents. If I'm a grandparent raising grandchildren, my income doesn't count. So I could have more money, but they only require the parent's income. That's not clear in the form. And there's also a question that says, if you know where the other parent of this child is, you are legally obligated to tell us. There are a number of people out there who would really not like you to wake up their ex-spouse or ex-partner and have the state come tell them that they owe Medicaid money. So we have a large abandonment at that point as well. And then there's a big statement at the bottom. If you lie on this form, if you misrepresent this in any way, you are subject to legal penalties, including imprisonment. So the phraseology and the way that you write the form is as important as the complexity of the form. So I am very hopeful that the state is working on the approachability as well as mindful of their legal requirements and the length of the form. Oliver, are you still there?
Yes, I am. Sorry about that. I had a little freeze. Okay. My last question here will be the timeline for implementing Medicaid if it were to pass, which I understand we're going to go out, we're going to vote next week. Would it be similar to that we're seeing in Oklahoma and other states that are working on this implementation as well? It sounds like the state of Missouri is already preparing and maybe thinking about the changes that would take place with the expansion.
So whenever you put something in like this, you always have legal challenges. So there's the implementation that is written in the code, and then there are delays that will come with legal challenges. When we went into this at the foundation, we knew that a portion of the work would be legal defense. And so we have partnered with the wonderful foundation in St. Louis, Missouri Foundation for Health, to be sure that we had the resources to defend this, because that could delay implementation. And you've seen in some states where the delay has been a very long time. In Maine, it was passed by their legislature 5 times, and the governor refused to allow a budget that would implement it. So they finally had to go to initiative petition in Maine and get it passed by the people. And even then he refused to implement it. And he has subsequently been voted out, and Maine now has Medicaid expansion. But there can always be big delays. I anticipate that we should, within a year, begin seeing people covered. I'm hoping that we can have all the legal defense done in that time period, but that is certainly better than where we have been. So I'm willing to wait. And then the other part of it is, how do you get people enrolled? How do you get them to understand to use the system? So there's a lot of work that comes on the enrollment phase. In expansion states, it looks as though the enrollment phase takes about 2 years to really reach the people that you're looking for.
Okay, thank you for answering all of those questions. A lot of the comments that came in just stressed the fact that your presentation was very informative. As physicians in the state of Missouri, I know that I found it to be very informative. And I think that we're going to go forward and we're going to vote next week. And I appreciate you taking the time to be here with us this morning.
Absolutely. And thank you again for WashU's leadership, and thank you for inviting me. It was joy.
Okay. Thank you so much. Thank you everyone who's tuned in this morning. If you have any questions, feel free to reach out to me if you didn't catch Dr. McCandless's contact information. I'm happy to connect the two of you if you would like.
All right.